Don't ask me.
Yeah, and everybody's just
Not every-
very much, it's the same thing, it's like, my brother, he was there, and so happy. Didn't take time out of it. And so, now they're careful.
I just don't mind that. Recording right now.
Oh, good. Thank you very much.
I think we have enough, right? So,
Make sure no one else.
Okay. I'll clear them today, and I'm getting tomorrow. Yes.
this is the next one. Like this. So, must be the same. So they're both house. Thank you. They're both house bills, but they're not. No one is actually.
From the table?
No.
Hot off the press.
All right.
It's literally still one.
Literally. Well, this one's 2789 and this one's 2475. Otherwise, you'll know with that out. So as an annually. Yeah, I don't know what. Yeah. Why did you amend it? Rather than two separate bills.
I know, You get together twice a year, there's a legal.
Exactly like
It's like, if we get together twice a year, we'll have a
piece of legislation that has to do with, you know, and it mentions the, it talks about the advisory and having it done in December. Well, today we meet in August.
There's a couple of guys out with, okay.
I understand that.
You'll find out more as you get more and more.
24/7.
Later. Everybody knows it, yeah, we're a small community, really. We really start knowing people, key players and whatnot.
Well, maybe that's the key advantage. Yeah, can I pull up this little stool here? Good.
Hey, everybody, thanks for coming. We'll go ahead and call the meeting to order. I believe we probably have a quorum, but we'll go ahead and do introductions, and I'll just take a formal count. So we'll start with you, Deb.
Hi, I'm Deborah Hauk, and I am the parent to two children that have MCAD. One deceased, undiagnosed, and one that is doing quite well, and he was diagnosed with it.
I'm Lila Olson. I'm an audiologist, and I still the audiologist a lot on this particular committee, and I'm the Arizona Early Hearing Detection and Intervention Coordinator.
I'm Eric Jack. I'm the MCH EPSDT Program Director over at Access and sit in the Access.
I'm Olga Ryan. I'm a registered nurse. I am representing community birth providers.
I'm Janae Fitzroy. I am the EZIP Program Administrator, the Part C Coordinator overseeing the Arizona Early Intervention Program.
Hi, I'm Debbie Johnston. I'm the Senior Vice President of Policy Development for the Arizona Hospital and Healthcare Association. I represent hospital healthcare.
And I'm Leslie Paulus. I'm Medical Director for United Healthcare. We're members of special needs and DEDs.
Hi, do we have anyone on the phone with us? Any members?
Kirk was there just a minute ago.
Yeah, he's our quorum-making aide. Dr. Alec, are you there? Maybe you might have your phone on mute.
Please, we hope.
Hello,
Okay.
Can you hear me?
Yes, who's this?
This is Deb Leddington with Northern Arizona Healthcare.
Okay, cool. Well, you're our aide then. Great. Okay. Just gonna wait a minute and see if we can get back a hold of Dr. Alec. We do have enough work. We do have a quorum though, so we can proceed. Yeah.
Yeah, Kirk Alec here.
Hey, all right. Thank you, Kirk.
Yeah, calling from the World Lysosomal Meeting in Orlando, Florida.
Oh, wow. Oh, thank you. All right. All right, so we have 9, so we have a quorum. All right, just to go through the agenda pretty quickly, the first item is the approval of the bylaws. I apologize, it's on me, these didn't get out sooner, but we posted these earlier in the week. I don't know if everyone had a chance to take a look through them. If you have any proposed changes or anything that might have gotten wrong, we can mark it up here, and then I propose we take a vote to approve the bylaws. Then we could move on to electing a chair and vice chair, discussion of the 2 disorders that are represented by Senate Bill 1571, SMA and X-ALD, an update with several items, and then a call to the public. Just for introduction, I'm Ward Jaycox. I'm Assistant Bureau Chief here at the State Laboratory, overseeing the newborn screening program and chemistry. So this, I'll be sort of facilitating this meeting, but hopefully with the election of a chair and vice chair, that will pass to somebody else. So any comments from the members on the bylaws, or any changes you'd like to see, or additions, or anything, corrections?
I thought they looked fine. I was curious if anybody had a better wording suggestion. Under section 4 on the second page, under committee operations, B, quorum. If a quorum is not met, a meeting limited to a call the public may be held.
Yeah.
It took me a couple readings, but
okay. So you're right. I guess it's not. It's a meeting with no business. It's just if anybody who attended wanted to make a comment. I'm open to whatever language you all would like to see.
Maybe just discussion and call to public.
I thought you could say the agenda would be limited to the call to the public, but it's not a big deal.
So if no quorum is met, referred to, the agenda would be limited to a call to the public, and Violet's, yours was?
Discussion. I would like to have that option of having discussion of the things we would have talked about otherwise. Right. Even though we can't vote.
The discussion of agenda items and a call to the public. Good. Okay. Any other comments?
Who gets the credit? Somebody worked on that.
That's all a group effort.
Thank you.
You're welcome. All right, then.
I have a couple. So, 3B, an inquiry shall be made of that member concerning their continued participation. Do we need to clarify who does that? Would it be the chair? Would it be?
Chair.
Okay.
Yeah. Or the chair can request a program. Staff can reach out. It probably should come from the chair. Yeah,
Okay.
Chair or the chairs. Okay.
I have seen through our council, it's very helpful when we clarify small things like that. And then just in review of kind of the intended purpose of the committee, I did see that it looks like the DHS director is the chair. That's what's listed on the DHS website. So should it be clarified in the bylaws then that the committee can then vote someone to be in that place?
That's, I don't have 36,694 in front of me. Is that on the website or in the statute? Anybody?
Maybe, yeah, I can
Oh, thanks. because that's how I operated under that assumption before, but then the last time I looked at the statute, maybe it just glanced over it.
It might be statute, but I do think that I also saw it on the website, so I can
Okay.
clarify where I found it. I just wanted to make sure that was clarified,
Okay.
if it is that position, or if, we are allowed to then, put someone in that position. Okay, so it's on, it's on the newborn screening website under, right there. So it says the committee is chaired by the director of DHS and meets annually.
Right. And that's the way it was in the past, but as I said, I would want to double check 36 and 694. I don't recall seeing any language in the statute that says the director is the chair. That's just reflected. My understanding of
694?
36, 694. Director shall establish, I think it says, is it G or H? Establish a committee.
H.
H, thanks.
Oh, it's G. H is the,
Listing of members.
it doesn't appear to indicate a chair.
Yeah. Yeah, I didn't think so. This is, when I started, this is sort of what I was told, that this is how it, the director had been the chair, but, yeah, again, looking at this, there's no indication that that's a statutory requirement.
Okay.
Unless, I don't know if you want to speak for the director, Jessica, if she feels like she or her delegate wants, if she or she wants to weigh in on that. I don't know.
There is not articulated in statute who can
Okay.
chair this, so if the committee would like to select a chairperson.
Okay. Yep, cool.
That's fine, I just saw it and I wanted to make sure.
Yes.
As you said, it's good to get these things squared away. You had another comment?
Oh, no, I'm sorry. Yeah, no, I think I covered it.
Okay.
You get to change your website.
Yeah.
Yeah. I made it up.
Thank you. And we should probably try to revise the website to reflect, I think we probably may want to update the advisory committee website for a call out to chair advice. All right, just one last opportunity for any final comments on the bylaws. So, I don't know if anyone, with the following changes, if anyone wants to make a motion to accept the bylaws, the changes are in 3B under attendance, adding, an inquiry shall be made by the chair or his or her, delegate or we're putting some language about whoever the chair would delegate. I'm not sure what the right word is. Designee, thank you, okay. And in section 4B for quorum, the quorum is changed the sentence to if the quorum is not met, meeting limited to the agenda, meeting limited to a discussion of agenda items and a call to the public may be held.
And that's where you are missing, between call and the, I think you are missing a two there, call to the.
Thank you.
That may be one reason why I read a little awkwardly.
Okay, with those changes, anyone like to?
I'll make a motion that we accept it with those changes.
All right, hearing a second in a motion, maybe a voice vote on whether to accept these bylaws. Yeah, we can do a voice vote. If there anyone who doesn't, we can go to a ballot, I guess. Motion on the motion to accept. Dr. Alec, are you saying something, or is that some background noise on the phone?
Background noise.
Oh, okay. So, maybe by voice vote, all those in favor of accepting, the bylaws as amended?
Aye.
Any opposed?
Aye.
All right, then, we will, accept the bylaws, we'll make those changes and post them, to the soon-to-be revised advisory committee webpage. Next is, the election of a chair and vice chair, which as described in the bylaws. I guess at this point, we could, the process I'm thinking of is to accept nominations from the floor. Of course, a member can nominate, themselves, and then, after that's done, we can, maybe do, well, let's just start there. We can figure out, we can either do a voice vote if there's one or two, or we can, pass out, these in lieu of ballots, and we can write your selection down.
Dr. Alec,
That's gonna be a problem. Say again.
is Dr. Alec not, wanting to be chair anymore? I just wondered.
No, well, I can't. I'm far away right now.
You're far away from...
Well, I to chair this meeting, you mean?
Or to serve as the chair of the committee.
Oh, I would like to do that. It's just that I can't be for this meeting. That's what you would have to do.
Okay, then we can... All right.
Well, if anyone, and if Dr. Alec is interested, I would be willing to serve as vice chair, unless somebody else really wants to do that.
Are there any other nominations for chair or vice chair?
I move that nominations be closed.
All right, so ordered. Nominations are closed. We can go to, again, if there's somebody want to voice vote. All those in favor of Dr. Alec as the chair of the advisory committee and Lilas Olson as the vice chair, please signify by saying aye.
Aye.
I think that's everybody. All those opposed, or anyone opposed? Okay. Then, congratulations, Dr. Alec and Lilas.
Thank you.
Thank you. So since Dr. Alec is no longer, or is not able to, chair the meeting today, Lilas, would you like to?
Oh, man! Yeah, I just screwed up big time.
The agenda's already printed out.
It is, that's true. So, did you want me to kind of go on to the next thing, or?
Yeah, it's
All right.
one thing, it's fine.
I need to look at somebody else's agenda, because I've got the wrong agenda. All right, so we're gonna talk about, SMA and X-ALD.
Okay, Jessica, did you want to give an update on the Senate Bill 1571?
Sure.
Thank you. This is, the, Assistant Director for Preparedness, Jessica Rigler.
Where should I stand? I'll stand in the middle. I don't know. I don't want anyone to have their back to me. Jessica Rigler, Assistant Director here at the department. Just to give a quick update on this, for those of you who were looking at the governor's budget, he did propose an executive budget that included a proposal for a fee increase for newborn screening that would allow the department to take on testing for SMA and X-ALD as recommended by this advisory committee. There has since been a bill introduced by Senator Brophy McGee. You have it in front of you, Senate Bill 1571. And that bill looks to adjust the newborn screening statute in order to create a single operating fee for the newborn screening program and set that fee at $117. So our current fee for the program is $101. If this bill passes, it would increase the fee to $117, which would allow us to accomplish implementation of SMA and X-ALD.
I have a question. Does this also cover full follow-up fees? For example, the newborn hearing screening, we want to make sure that you have adequate funding to cover follow-up on all babies that don't pass rather than just high-risk babies?
I believe that was incorporated into the budget, that demographic follow-up, laboratory testing, all of those components were included.
And the hearing test.
Oh, you're speaking of all disorders.
Yeah, all the
Yeah, so,
particularly my interest.
Yeah, gotcha. The fee increase incorporates funding that will cover SMA and X-ALD implementation as well as some of the structural deficits that we're running within the newborn program as well. So it kind of has those three components, adding the T-test and working to correct the structural deficit as well.
Will this change the methodology that you use or the equipment that you're purchasing for testing or?
For XALD, it will be a new kit for the existing metabolic panel with the tandem mass spec. And for SMA, do you want to?
For SMA, we will have to redo the platform. We're hoping to multiplex it with our current track screen, to reduce space and to, as far as blood spots and all of that, hopefully build some efficiencies. That's what we're planning on going as a multiplex assay for that.
One other thing, Sonal, would you mind if you give an update? We also received a SKID grant.
From,
I'm not
Cure
sorry,
SMA.
SMA
It
grant,
was a
sorry.
Cure SMA grant, for $100,000. So some of that will be used, for purchasing some of the equipment and doing any educational, outreach and setting this up.
Transparency, for all transparency, I probably should mention this, and Jessica and I have talked about this. The way that I understand the department wants to do this is the hospitals would be responsible for the total, for both, the total cost of the program, including both, which is right now broken into two different, fees. And we just want to make sure that there's a process in place, for the hospitals to get reimbursed, by the insurers for those patients who are insured. We need to work through that mechanism because the hospitals do not conduct the second test. That's typically done at a physician's office. And so, and some of the babies are born in non-contracted hospitals because sometimes it's an emergency. So we just want to make sure all of that gets worked out as we work through the legislative process. I have heard that there are some hospitals who are concerned about the cost for those uninsured patients. That's a different association who represents those hospitals. So I'm going to let them deal with that. But I think my folks are really just concerned about making sure that the health plans do cover the total cost of the program for their insurers.
Any other comments? We move on to updates. We start with Russ.
All right. From our perspective, the RUSPA, there's still two disorders that are not on our panel, MPS 1 and Pompe. And the only other update for the RUSP is related to two additional bills that are in front of the legislature right now, which I believe you also have. And I think they seem to be 2432 and 2789 seem to be variations on a theme. I'm not sure why.
Yeah, I was asking for clarification from our legislative liaison on these. It seems that 2789 is an update to 2432. It has a quicker implementation date on it, but they are nearly identical other than that. So, and 2789 is the only one that looks like it's been assigned to committee. There's been no action on 2432 as I've read. So I think that one is just a replacement for the other.
Thanks.
Ward, can you repeat what two conditions? Pompe's and?
MPS 1?
Okay, thank you. That's what I thought you said. Sorry.
Has there been any update on CMV?
Not that I know of, but I haven't really checked. So I can put it as an action item to look that up.
Yeah, I don't believe so, so just add it to the next meeting. Fine.
Can I add something? Related to the rest, the Secretary's Advisory Committee is not able to meet because there's no budget for the Advisory Committee, so they haven't held a meeting in, gosh, since late summer, early fall. And so there's no plans currently to hold any Advisory Committee meetings. So, because of the Newborn Screening Phase 5 Act. Phase 5 Act has not been reenacted, so it's all based on that.
Gotcha.
So there's no, there's nothing up and coming on the RUS.
Mm-hmm.
that was in talks prior to them
So there's-
stopping meeting.
There's nothing in an evidence review right now that you know?
For CMV, no.
Or for anything?
The only thing that they're testing, what is it, New York is piloting Duchenne muscular dystrophy.
Okay.
But there's nothing been presented for data to make that recommendation on that yet.
Thanks.
Does that being funded have other implications for us?
Secretary's Advisory Committee?
I don't know.
Shall we move on to disorder nominations, review decision process?
As we discussed at the last one, we're putting together a nomination form and flow charts. I've sort of held up sending that out just because the flow chart this is the first time since I've been here that we've had new disorders that a governor's office has said, yeah, we're going to support legislative initiatives to do this. So I'm kind of, as we're going, learning and having to modify and adjust things. I thought, though, I could send out a draft of the form. I believe this would be allowed under open meeting law, to each of you to make comments on individually and just send back your comments to us so we can finalize a candidate nomination form that we would post on the website, and then anybody else could,
Does House Bill 2789 impact that at all? Because it seems like it is really looking at the process for adding disorders as well, so.
I haven't looked at it since the first time. I thought it was just a report on what's report and evaluation.
Line 20 talks about analysis of the process of adding disorders.
Yeah, I'm not really clear what that means, an analysis of the process for adding disorders. I mean, we could give the same, standard work for adding a disorder. I mean, that could be kind of, I guess that could serve in that, to fulfill that requirement in terms of all the different options. I mean, from when it comes, well, that's for adding a disorder. I guess if we start at the advisory committee stage, that could, what we're working on could suffice for that, I guess, as I'm kind of reading it right now.
Do you, in your department, have a standard operating procedure for reviewing which conditions that you bring here to the committee?
The standard work we're working on is for when the committee's made recommendations, what happens inside the department. In terms of, the only thing that I think we would have after this form is finalized, if anybody would be able to fill out the form and submit it to the committee for consideration. How many other, that was your...
So you're saying any stakeholder could
Sure.
submit, and you put this on the website, and they could access it, and then that is the process to get a new condition looked at.
Generally, I mean, somebody could always, just quote a bill and try to add it legislatively, but that's the process we have. That's how it works.
I just think that how often would you have to do this analysis?
It's annually, but then it seems like it ends. I thought there was a section that's repealed from and after June 30th.
Yeah, it's 2021.
Yeah. So it seems like it's past, it's on or before December 31, 20. It seems like a one-time thing almost.
So do they want the committee to approve a process, and that's part of your analysis?
I have no idea what the intention behind the bill is.
Forethought, I think.
Yeah,
So
I have no idea. I didn't even think it addressed the committee.
When I was reading it, it looks like they are looking for a report by the end of the year where we really go into the details regarding the only couple of conditions we don't have on the panel.
Right.
And it potentially would be to maybe, in my assumption, to help them make informed decisions on, where we may be going with recommendations. But one question I had is, have we ever, has this committee regularly completed reports like this, or is this a new request?
It's new to me.
Okay.
Since I've been here.
I'm thinking it would also include criteria that we look at and exclusionary criteria. Something should be written up as guidelines on it for the evaluation and so how does it get in? How do we evaluate? How do we then make our recommendations? Something should be written up.
And that's kind of what we're working on. So in addition to the candidate nomination form, we talked at the last meeting about a proposed, sort of tracking system for it. If it's on the RUSP, and, I don't have the minutes in front of it. If it's on the RUSP and it's, not costly to implement, it would be, sort of an accelerated review, and then sort of the other extreme, if it's not approved by the RUSP and nobody knows much about it, might require, either more review or, what you want to do in that case. But it's something for you to read. We can send that out to sort of the draft of those tracks, and in light of this bill, you can sort of react to that and make a comment.
Okay.
Is this a bill that's supported by the department?
I don't know.
The department remains neutral on any pending legislation.
I'll remember that.
So, are there any current standing or ad hoc committees through this?
Nope, not at this point, but, for the bylaws, it's open.
So, the only thing that I would want to bring up is that if we have to work on a report, if this does pass, if this does go through, if we have to work through a report, creating potentially an ad hoc committee to do that work, or adding the actual work itself to the next committee meeting, it would seem best to maybe be done in an ad hoc committee, but the only time you can establish ad hoc or standing committees is through a committee meeting like this. So if this would need to be done, that we would have something in place to be able to work on it.
I move that we can establish an ad hoc subcommittee.
I'll second that.
Could I interject real before you take a vote on that? My reading on it was the department would be responsible for putting the report together.
So
what was
it's
the
not
role of
the
the ad hoc
committee?
committee?
In conjunction with
So in
the
conjunction
advisory
with the newborn screening advisory committee.
Okay.
So you get volunteer support, whether you want it or not.
Okay, thanks.
I mean, what I would envision happening is you guys do the report, and if you bring it to the committee in August, and we say, let's get that, or not.
But they could also do the ad hoc to get additional input so that no surprises at the meeting. It doesn't say they have to. I'm just saying that we can.
So the question from the committee to the department is, do you need support?
And it does say, the Department of Health Services in conjunction with Newborn, Advisory Committee as well as Access, and I know we have an Access representative, but just taking into account if, Eric would need more people as well.
But, because I think part of that report is the fiscal, so obviously that we would have to assist in that data gathering.
To your question, I certainly wouldn't want to decline offers of assistance for something like this, so.
So do we still need a committee or the ability to create a committee if this happens, or?
Seems like a good idea.
Okay, so
then how do you choose those members is my other question. I mean, is it just volunteer, or does anybody want to be on the ad hoc committee goes out and if you need help or want input? And then we sign up.
It works for us.
That's obviously Dab and others.
Yeah. And we just put out, similar to this, we notice subcommittee meetings in the same way, and we'd have to be on a much more regular basis than twice a year, but, yeah. We just support the same, support the larger committee.
do we need to amend that motion, or does that cover it? can't remember exactly what your wording was.
So you would make decisions on any ad hoc committees during a committee meeting, so all of the work is done in public, so they are aware of what we're doing, not making decisions kind of, outside of public. So if that would be, I would say if Department of Health Services would suggest that that is something that you would like moving forward, then we could potentially vote in just creating a committee, not necessarily having to have all the details right now, but just so then the public could be aware that that is a decision that we've made, and if needed, we can move forward with.
All right. Shall we vote on that? Everybody say aye if you agree, nay if you disagree.
Aye.
Thanks, Kirk.
We'll start
Our
working
chair.
We'll start working on setting up the infrastructure for it to support the subcommittee.
Sounds good. Okay, are we done with that? We move on to the next item, which is parent support.
The only thing, this was a requested addition to the agenda. The only update that I have is that we have, as a department, as a program, have accepted Hands and Voices offer for to incorporate Guide by Your Side parent support for hearing disorder. And it's something I think we're also looking at other. And I don't know the details of this, Fran probably knows better than I do. There's other organizations that might be able to offer something similar, and we certainly are open to, like Raising Special Kids, or Ocean apparently has something they could offer that we're, willing to try and figure out how to incorporate that in some way for other disorders, depending on, what resources we have in our ability. But sort of, it's almost like we're piloting it with hearing, and so. Taken a while to reach that decision, but that's where we're at right now.
Anybody have any questions or comments, discussion? I like it.
I would just like to understand better what that link is. So my guess is that when a child has their second follow-up hearing screen and then is scheduled for a diagnostic test, that typically...
It's usually the
right.
link is post-diagnostic after a child's
So
diagnosed.
would the parent-to-parent support be connected at that point?
Yeah.
And are we talking about the state lab creating that link, or is normally the specialist?
I probably just let you answer that, or maybe you want to answer that question?
I couldn't hear the last part, so repeat it.
When the link is created and with the parents and how?
So what we've done previously when we were offering the follow-up, the parent-to-parent support within the follow-up when it was with the EAR Foundation, it was at the time of confirmation of diagnosis. So it was at that process where we connect with the parents and we let them know, we know you have a confirmed diagnosis of hearing loss. And it's bridging that gap into EI, making sure that they're aware and know, or if they already have established connections with the EI. So parent-to-parent support is also part of it. We consider that to be part of the early intervention. It's connecting them to Guide by Your Side, connecting them with Raising Special Kids, making sure that they're under the AZIP or ASCB that are available to them, making sure that the families know about them and are specifically connected to them.
So this is something that would be, the parents would have to agree to,
Sure.
have the support.
So it's just in addition to your usual process of making sure they're connected to appropriate, support in the community.
It's just adding that extra layer of
Yeah.
support for the parent-to-parent connection, that's a similar, situation, like someone who's the same diagnosis.
They just ask to, being a parent of a deaf or hard of hearing child.
Hey, if someone's on the phone, would you mind muting? We're getting a lot of feedback. Thanks.
So as parents of deaf or hard of hearing children, as with any disorder, I'm sure, it makes a difference, the impact that's there for a parent that meets another parent that's going through a similar journey or has been through that similar journey, connecting with them, understanding why they should take advantage of the early intervention. What are the, what are the pros and cons to it? What they're gonna be facing? What kind of, what professionals are gonna be telling them and talking to them about? And for them to help, it's a way of helping them understand the process and understanding the urgency of why they should follow through with some of these, processes as far as leading all the way into intervention. So, making that connection with a parent, it helps improve some of the outcomes for the families.
Absolutely.
I see the value in it. I think I understand what it is. My question was about who pulls the trigger. And so my guess is that the EAR Foundation was finding out that a baby qualified through the test results being entered into the system.
Yes, so the follow-up, it was
So in
part, it
other
was part
words,
of
the
our
state was
contract.
providing a backup,
But
as well as the specialist potentially saying, here's the parent-to-parent support thing, if the specialist was great at what they do,
which
hopefully
doesn't usually happen, no. I think that was part of our contract, when the Your Foundation had the follow-up contract, it was part of our contract to link with parent-to-parent support. When that contract was over in August, that was the end of that, so this is my understanding is a way of picking that up, a bridge to restart that particular program. So it's contacting the parents and offering them and getting consent for them to be your.
I'm thinking about the responsibility, who owns the responsibility, and when we're thinking about 30-something conditions, I tend to think of a child going to Children's Hospital and having a very rare kind of disease, and I'm guessing that the specialist at Children's Hospital might be the person who says, by the way, there's this fabulous organization that you want to get linked up with. And does the state need to continue to be that backup source, or?
I think what we found was that we've been actually doing this particular program for 16, 17 years, and we tried a bunch of different things, including having the specialist do it, sending out letters, postcards, all that. And what we found works 90% of the time is when the follow-up person does it, and they do it immediately after diagnosis, and it's the parent that does it. So I think through the QI process over many years, we've found that this actually works, whereas some of those, having the specialist make the referral, it didn't happen. Yeah, it didn't happen, and I think that they were willing to do a passive referral. And one of the things we found is asking parents to do a cold call is not what happens. You've got a parent of a child, it's just not, it doesn't happen, whereas if you call them, they're very interested in it.
I have a few questions, and I kind of wanted to piggyback off of one thing that you were saying, but, so I also do see, some duplication here in the system if we look at the system as a whole. So child is getting diagnosed with a hearing loss. That child is then, required by the audiologist, the person making the diagnosis, it is a required referral over to early intervention. We have a system now where that referral is coming into early intervention, being assigned to both. So when I say AZIP, and early intervention, I'm talking about all of our service providing agencies. That would be our AZIP team-based contractors, Arizona Schools for the Deaf and Blind, and DDD. So that child is coming into AZIP, getting assigned a service coordinator from day one. Prior to some changes that we made, there were some gaps in the system where a child did not have the service coordinator. They were being sent directly to ASCB. They were closing without being provided procedural safeguards. So we've shored up that process to where when a referral is coming over for a child with a diagnosed hearing loss, it's going to both our team-based contractor and ASCB at the same time. So they have their service coordinator. They're afforded all of their rights under IDEA. The service coordinator's role then is to make sure that that family is set up and in support and in collaboration with ASCB in support. They're supporting the family to make sure that they're being directed to all of the agencies that could potentially support them, and this being one of the biggest ones for this community of children and families. So from an early intervention perspective, I would need to fully understand what does this look like prior to being a referral to early intervention, so I can inform the service coordinators of what they should expect. Because if a guide by your side is being support to all of these families, only some of them, a portion of them, because there may be a gap in which children are able to be receiving services through Guide by Your Side. So depending on the diagnosis or any kind of restrictions that they may have, so I can inform our service coordinators so they really know how to help navigate that family since that is their role. They also are required to go through full child and family assessments, which really dive in deep to see what are all of the services that you need, what are all of the community resources that you need, and then they can support in assessing if Guide by Your Side is a resource for that particular family that they can then send them to. I don't want to have any duplication of child already receiving support for Guide by Your Side, but then being referred again and some confusion. So I think I just want to better understand what that looks like. And then also any restrictions that Guide by Your Side may have. So are we saying that for every child with any level of bilateral or unilateral hearing loss could get support? And are there any restrictions as far as areas in the state that they support, fees for the program, any of that, where we would be secluding any families, just so I could better provide that information to you.
So can I ask a real quick question? Does AZIP cover every child with hearing loss of any degree, or is it only those that then you have delays as specified for your other?
That's a great question, and it's very complicated, so I'm going to do my best in trying to explain it. AZIP, we in order to be eligible for early intervention, a child has to have a significant delay in at least one area of their development or have an established condition. So in our current policies that have been in place for quite some time, there are two areas that talk about eligibility under having a hearing loss, and neither of them have correct language. So we are working on that right now. So it does say that a child would have to have I'm going to put it in quotes, a significant hearing or vision loss, which that's not how we measure hearing or vision loss. And then the second part says a 50% delay in their hearing or vision, which again is not how we define that. It gets so we are fixing that. We are going to be going out for public comment, and I really strongly would advise anyone to look at that, make sure that you kind of agree with how we are going to change that verbiage. But that is one area that has caused a lot of confusion, because when we talk about early intervention, early intervention is a 5-state agency program. So Arizona Early Intervention Program State Office, lead agency under IDEA Part C is DES, but with the AZIP program having the administrative authority to carry out all functions. But we are a 5-state agency program, meaning all of our state agencies really work together to collectively serve these children. But out of 5 state agencies, there's 3 service providing agencies, being our AZIP team-based contractors, EDD, and Arizona Schools for the Deaf and Blind. So currently, Arizona Schools for the Deaf and Blind has a little bit different of an eligibility criteria to be eligible for ASCD than AZIP does. So we have had a gap in our system for a while, and it's been something that we've been working on very diligently with this community. But in AZIP policies, we do not state that a child has to have a unilateral or bilateral loss, and so that's one thing. So essentially, if you want to take our language with how we should be reading it, is if a child has a complete unilateral, so a unilateral loss in one ear, profound, should be eligible for AZIP, and they are eligible for AZIP, and we have many children eligible for AZIP right now with a unilateral loss. However, they don't meet ASCB's criteria, because ASCB's criteria does state that it has to be a bilateral loss. So the actual service provider on the team that would be most appropriate to support that family, given the hearing loss, not saying that there may be other things also where we would have other service providers on, but that team member would be a hearing specialist, a hearing teacher, teacher of the deaf through ASCB, but those teachers are not currently on those plans because they don't meet ASCB's criteria. However, they're eligible for AZIP, so we're trying to work on that right now to expand to have our policies and ASCB's maybe match a little bit better so we can ensure that the right service providers are providing services to the children.
So that was my concern, that perhaps it until that's all sorted out, it would not be bad to have, people perhaps get a second message or referral so that they don't get no message.
Absolutely, absolutely.
So,
Not to
but
mention
you want
there
to
was a whole bunch of questions there regarding our programs, so I'm gonna try to remember a couple of them. First of all, there is no fee, it's completely free for families. Second of all, there's no restrictions in the state, we serve the entire state. We're completely unbiased to whatever type of loss they have, whether it's mild, moderate, unilateral, bilateral, whatever the reason is. And being able to connect them to us, we're able to connect them to other families. So the level of service they're getting from a professional is very different than a parent-to-parent connection. It's a completely different relationship. And 90% of the parents that we deal with appreciate that relationship and want that relationship. We have a parent here who's been, who's benefited from that. And so, it's a totally different thing. And so when we're calling at the time of diagnosis, most of the time they've heard from EI, they have a service provider, they've gotten all of that worked out. There are times where they've declined services, and we're able to talk to them and say, hey, this is what we benefited from it, this is why you should really think about it, take advantage of what the state offers, and we're able to help that family get those services that they need, that maybe they wouldn't have otherwise, or they have that service, and that's great, but they also want to have our connection and meet other families and go to picnics and have educational workshops, and it's a completely different relationship. And if a family has something more than just hearing, we're able to connect them to Raising Special Kids or Ocean or whoever else is appropriate for that family. And everything we do is in a completely unbiased manner, so they don't feel that pressure of having to make a certain choice. And so I feel like, I don't know what other questions there were in there, but,
No, I just wanted to know all that so I can make sure if there's any areas where there would be gaps that we can help.
Right, and that's part of why we want to do that, to help fill in those gaps as well.
But I think from a perspective of the old person in the room that's done this, is we've tried this before with Raising Special Kids. We had a contract with them years ago, and we had 2 or 3 families a year that ended up getting connected. We tried the same thing with audiologists, and it was 4 or 5, families that got connected. We tried using the early intervention program, and maybe it was 5 families that got connected. Now we're looking at 100 or 150 or whatever. So I think over the years, we've tested a bunch of these different methodologies and settled on something that works.
Right, and as a parent, I can't see the downside of having that extra layer of support, especially when it's not costing anybody anything extra, and it's supporting families, and we know that that's what families want, that's what the research shows, that's what we know, that's what we,
And I hope you didn't hear me
Oh,
saying
no,
I
no.
think it's a downside. I want to make sure I have the right
No, absolutely.
and instructions eligible.
No, we appreciate that.
Yeah,
We
so
want to
if there-
continue working together and,
Yeah.
And if I may, I just want to jump in too and say that we also have parents that have children that are not just deaf and hard of hearing. We have those ones that have those other medical issues or other ongoing things that they're dealing with as well. So it's being able to connect with the parents in that aspect as well. So, we have a variety of opportunities that we are able to provide for the families as far as understanding the systems and making those connections. I feel like it wouldn't hinder anything that you're doing on your end. It's really just providing more for the family. I have a child myself that I didn't hear about Hands and Voices until she was already 3.5. And I should have heard of Hands and Voices from the beginning.
Absolutely.
And I didn't. Nobody, not my audiologist, not my early interventionist, not anybody.
And
So-
I do agree, and part of that also is wanting to make sure that we are supporting our service coordinators and our service teams through early intervention and understanding what this other resource that's supporting the family that they're supporting is. So I'm wanting more information just so I can make sure that, when it should be captured on their IFSP that they're receiving services through other community partners. So whatever it is that I would need to know, if this is actually a set thing, so I can push that forward with the service coordinator so they know, and they appropriately invite you to IFSP meetings if they want to be, if you
And
want
we
to be
would
a
love
part
to
of that.
set up something with you where we come and meet with your providers and tell them about us and make them understand, and offer that support to them to go meet the families, or, we're more than happy to do that.
You answered all my questions, and I just have one other question, sorry. So what does that look like? So when a child has a diagnosed hearing loss, how is so all of those test results, all of those children, are they, how are we getting that information over to Guide by Your Side?
Right now, we just, agreed in principle for to accept the offer support. We're setting up a meeting next week to sort of hash out exactly what that's gonna look like.
Okay.
But in the initial phase, it would, I don't think there's any type of health information that's going over, but again, we just have to work that out.
So the only thing I read, and I'm not sure if this actually would move forward, but in SB 1571, it does say at the bottom, test results are confidential, subject to the disclosure of the provisions in certain sections. Now, I don't know what those sections are, just to keep that in mind while you're making process.
Sorry, say that, could you refer to that?
So it's in the SB, it's right there. Test results are confidential, subject to the disclosure in the provisions of whatever sections these are. I don't know what those are, but, keep in mind, if something like this passes, then just, to think about that.
So if I may, just because I know when I was working for the Year Foundation, did the follow-up, and they had the contract, the database system that they use, HighTrack, they're able to limit the amount of information that a user has. So that's something, like Ward said, we haven't gotten down to the details, and we haven't gotten to that point of what what exactly our rules are. We're gonna iron those things out. But I will say, as far as limiting whether or not we can see, audiograms or test results or anything like that, that's absolutely doable to where that can be restricted, that we don't see that. And then it can be in a conversation with, if the parent chooses to talk about it with us.
Yeah, because that was my take on it, was we weren't, like, pushing the parents. We're just sort of making them aware of the opportunity to have the service, and then they would, decide whether or not to accept it or not. If they accepted it, then, they would, I suppose, find some sort of consent to, to share other information, but people are mindful of protecting the child.
Thank you.
Any other discussion on this one, or move on to the next? All right, statutory requirements for hearing screening education. And I'll just jump in on that one, because I think that, it's probably a real quick one, but I know part of our rules requires that hospitals, educate parents about the hearing screening process. And I know that some changes were made, and I'm wondering if we have any update on if hospitals are doing that and how they're doing that now.
From what I know, so we were accomplishing that in the past by, every parent, just like we do with the.
Sorry, just for the recording, just introduce yourself.
Yeah, hi. I'm Wendy O'Donnell, the education manager for newborn screening. So in the past, I believe they were given a pamphlet, just as we do for the blood spot, the blood spot condition, which can include hearing. So that met that requirement, and hospitals would give that to parents, at the time of the screening, and kind of explain everything that was going on. From what I understand, that was funded through a grant that we no longer have, the printing of that hearing screening pamphlet. So what we do now is offer hospitals, we still have some in the building, so if they are in need of those, we send them to laminated copies that they can use for bedside education. So not every parent needs to take one home. Not every parent, is likely to look at it after it goes in that folder. So that's how we accomplish that now.
Do you know how many hospitals are actually using it or not, or is that the question you don't?
I don't know that.
Because I'm wondering, since it's a mandate, if there's any ability to.
And it is included in the purple parent flyer that hearing is included in that.
Oh, in the generic?
Yes.
Okay.
With all of the other conditions that we're screening for, CCHD and the blood spot as well.
I mean, under licensure regulations, hospitals have to comply with every single mandate. So if it's mandated, they need to be complying, and they could be, there could be a compliance survey, and it could be found out if they're not doing mandated education.
How do you get a compliance survey?
Arizona Parent Trust, I think, is checking it, but I haven't been on a survey, so I can't speak exactly how that works.
We do. But to Lilas's point, though, not every hospital is in the trust. This is a voluntary organization. There was only maybe 5 or so hospitals that provide delivery services that are not part of the trust. So, but this is one of the things with the ADHS representative on a site visit and or the Access representative.
Okay.
I mean, obviously, if there is, concern that there are hospitals that aren't doing that, you can always let the association know or the alliance know, and, we will do that education ourselves and remind them that there's a requirement out there, and we can connect them with the resources to do that education. We're happy to do that. That's one of the reasons why we exist. We want to make sure that they are in compliance.
Okay, thank you, I appreciate that. Anybody else have questions about that, or move on to, data transparency? So this is one I added to the agenda as well. I think, one of my concerns is that in a meeting like this today, we have no data about the program. There's nothing that we got today that talks about how the program's doing or what is happening, or, are we meeting guidelines? Are we finding kids? Are we, all of that. So I think one of the things I would really like to see is this committee able to get relatively frequent updates about, program data, so that so as a committee, we're kind of knowledgeable about what's actually going on.
Similar to the partners meeting where you get more data.
Yeah.
So for every meeting, you're suggesting adding like, confirmed cases, the budget what would you like to see?
Whatever's relevant to, benchmarks for performance for the, I think in hearing is how many cases have been identified, whether they were identified in the 136 timeline.
What about an annual summary that they have to provide anyway?
I think annual would be okay. I think each meeting, though, we probably should have something that talks about, I don't know if you have to have a
But
full.
one of the meetings could just have the annual
Yeah,
summary.
yeah, because I think having a committee that doesn't know what's going on in the program is kind of weird.
I don't disagree. I absolutely, I want to make sure we're in alignment with the purpose and role of the committee with whatever is being suggested, and trying to pull it up, but of course I don't have access right now. From what I've read, the purpose and the role of the committee is to nominate and provide advice on new.
Yeah, that's right there.
Yeah, so maybe, I just want to make sure, not saying that we can't do more, just wanting to make sure.
Not an
that we're-
oversight committee.
It's a,
Yeah.
Right.
G.
It was perfect.
Oh,
Yeah.
sorry.
G, provide recommendations and advice to the department regarding tests that should be included.
I think also we try, so, I know that my first meeting, so that was like November of 2018, we did have a summary for the confirmed cases of 2018.
Yeah, and I
Or
like having that.
2017, so, we may have missed it last year for the 2018 cases at our June meeting, but I was thinking about that when we were putting everything together for this meeting. I don't think we have confirmed cases for 2000, it wouldn't be a complete picture, right,
It would just depend on the year. But like for hearing data, we provide that at the stakeholder meeting, the
Right.
most current EDI data
Right.
that has been submitted to the CDC. We provide that to all the stakeholders.
And
send
even
that out.
if that was what you provided to this committee, that would be fine with me, but I think this committee.
I think that stuff is very helpful context. I agree with you that, in terms of deciding how important it is to include a new test, we're looking at all the risks and benefits related to that family. And so the context of what it requires in terms of adding the test into the state procedure, and what it costs in terms of the documentation, the follow-up, and what it costs in terms of the family's experience are things that we should be considering. And I think those kinds of data on I was thinking productivity, which doesn't sound right, but I think that's helpful context in terms of this rule.
Again, I may be overinterpreting the open meeting law, but would you all be open to sending suggestions to us in terms of what you would like included on it?
So we could fulfill this function kind of with this lens on it. So regular, like what updates would be helpful for us to then be able to fulfill this, or just regular updates on all of them?
I suppose within the context of the, yeah.
Okay.
But I'd leave it to you to tell us what you think would be helpful to help you value, be aware of the context when making decisions about what to have.
In my mind, the annual summary kind of gives you a global picture of how you've done for the year and what issues are coming up and areas that...
Well, and I think you could read this as, theoretically, you could remove a disorder as well. And so looking at each disorder, whether it should be there or not, is part of our mission.
Yeah, if we decide that, or figure out that, gee, that one hasn't been discovered in 10 years because of something.
Yeah. So I think a little bit of information about each of the disorders would also fit under this.
What our status is on our, the Tableau annual report, or that's still working on? Okay. I think we should be able to provide something, at least in terms of the annual report. I mean, it seems perfectly reasonable.
Do you post your annual reports somewhere online, or?
We used to have them on the website, but we've gone through some trouble with business intelligence software, and I think we're still trying to get that capability back up to supposed to actually prepare it and post it. But I don't know if you have an update for that.
Well, and I'm just looking here, HB 2789. One of the requirements will be an assessment of the number of newborn infants in this state impacted by each disorder listed on the recommended uniform screening panel. So I think that could be, as Dr. Paul has said, looking at the state incidence of some of these conditions, because she and I will look at it from a different lens than other people. How many SCID individuals are going to fall into our bailiwick that we may or may not have already. We'll see if our predictions of incidence is actually true, or if we have a higher incidence, then I have to go back and we have to do some fiscal forecasting to accommodate for that change. So I think Lilas's point and Dr. Paul's point are very good in terms of just the annual report will give us a snapshot of this is what happened last year, which then we can use for historical prediction for a coming year. At least that's how we look at it at the agency.
Any other comments or discussion about this? I don't think that we need a motion, do we? All right. Call to the public, I guess, is the last thing on the agenda. All right.
I had a request for adding something to the next agenda that either you or Dr. Sanchez can try to help with. And that is, it would be nice to have a subject matter expert come and educate me, and I would like it, on cell-free DNA testing and that change in maternal testing and what that...
DNA, you said?
Cell-free DNA testing.
Cell-free. I heard that wrong.
I don't know if that's the term that encompasses what I'm thinking of, but basically the ability to do genetic testing for parents as carriers is exploding, and what that means for newborn universal screening is a new frontier as far as I would guess. And I think it would be nice to have somebody come and talk to us about that.
Did you have any comments about that, Kurt?
Everybody's just going for whole genome.
It's just really interesting. He's gone to the beach. All right. Does that sound reasonable for us to request the, that
Yeah,
from
we'll-
the department to come up with a subject matter?
We'll do our best to find somebody, yeah.
Kirk may be able to fill that,
Yeah, okay.
possibly, so. Or he knows somebody who can.
Right.
Anyone else?
I just, wanted to recognize, Access and Department of Health Services for all the work that I'm sure you put into the analysis for SMA and X-ALD to get to where we are now, so you've done a great job.
And I'm actually seeing results
Yeah.
in our members, so very exciting. Yeah.
I'll take that back to the finance people. I need to give them a kudos.
Yeah.
Because they're working hard on.
I'm sure they are.
Yeah, they certainly are. They have, those actuaries, yeah, they really crunch those numbers.
I was unable to mute my phone, but now I'm ready to answer your question. What is the question?
We're talking about cell-free DNA testing, and we need a short course on it perhaps at the next meeting?
Oh, yeah, so you're talking about non-invasive testing of mothers? Is that what you're talking about?
And what that may mean for universal newborn screening in the future. I mean, I sort of feel like the future's now, but the future's here.
Well, I'm not sure exactly what you mean by cell-free. I mean, I know what cell-free is, but I'm not sure how it applies to this situation. So when I get a better feel for what the question is, I'll be glad to answer at the next meeting.
Well, and I may not be using the proper terminology, but essentially the ability to do genetic testing of parents as carriers.
Oh, yeah, you're talking about those huge screens that are out there, 106, 206 disorders, et cetera, yeah.
Yeah.
So, what is the question? I mean, how to use that technology?
How it might impact universal newborn screening.
Well, when parents figure out that they are carriers for something, they're going to start demanding that that particular entity be on newborn screening. So it's going to get a little tricky. I think we're going to end up doing something called a whole exome slice on all babies that are born, but we can take this up later.
Yeah, I was asking for a SME presentation on this topic for the next meeting.
Okay, if somebody will define that, exactly what you want me to talk about, I'll be glad to do that, but right now I'm not exactly sure what you need.
We'll get as close as we can, how's that?
Okay, be glad to.
All right. Anyone else? Any other discussion, call to the public? A motion to close this down? Second. Vote? Everybody say aye.
Aye. Aye.
We're done.
Thank you, taking the following passengers. Newark, Austin. Please make your way, Terminal A.
How are you? Good. How are you? I had asked when you were studying in person.
So what is it? I'm into Arizona Health and Human Plan. Yeah, there's so many different acronyms, right? So I'm sorry. That's okay, no, that is okay. Yeah, I knew it had to be something I know.